Hello, this is Dr. Ruby, and welcome to the second lecture for Module 8. In this lecture, we'll be discussing the forward head posture. So first we must identify, what is ideal cervical posture? What are we looking for? What should we say to the client is the goal? This identification comes from Newman and basically says that the cranial portion of the sternocleidomastoid muscle should be slightly behind the sternoclavicular joint. And this is where our head should lie in relationship to our shoulders. This unique posture is created by a balanced craniocervical guy wire system created by four muscles. The four muscles are the sternocleidomastoid, the scalenus anterior, the semispinalis capitis, and the levator scapula. In this photo, you can see a picture of the sternocleidomastoid. If you look in the picture, you can see that the craniocervical portion of the sternocleidomastoid is slightly behind the clavicular portion of the sternocleidomastoid. So this person is following in a normal cervical posture, not a forward head posture. In this photo, you can see the scalenus anterior. And this muscle is actually a deep neck flexor, and we'll be talking about how in the forward head posture, this muscle becomes shortened. In this picture, you can see the semispinalis capitis, and you can see how it travels from the cranium through the cervical spine and then attaches to many of the other muscles that travel down throughout the entire spine. So we do see a relationship of the position of the head according to the amount of flexibility of the other muscles that travel along the spine. In this last picture, we see a picture of the levator scapula muscle. Now this muscle will become very short in the forward head posture and be one of the main forces in pushing that head forward. This muscle has some implications even into the shoulder girdle, and we can see a lot of effects in the scapula because of its attachment to the medial superior angle of the scapula. What are the functions of the neck muscles? Well, really, they're more than simply a support and movement for the neck. They have an important role in maintaining our equilibrium. They hold our eyes level so we can see and move in our environment, and they're strongly influenced by the limbic system. An impaired function of this system can cause changes in muscle tone. So we often see that stress will affect the cervical muscles, and some people will have pain in that area because of physical or mental stress in their environment. When under stress, there is increased activity of the neck muscles, and this is noted in several research studies. If we go back in history, the shoulder and neck muscles are involved in a defense mechanism, and they are activated by stress and fear. Our head is something that we really need to protect, and in earlier times when we were being chased or we were being attacked by an animal, the head was the thing that we would try to protect, and the cervical muscles make a great play in that. So still, when we are subjected to stress, our body responds with protective mechanisms for the head, which involve the neck muscles. Along with the shortened neck muscles, as you could see in the picture of the levator scapula, you do see a change in the shoulder musculature. If you take a look at this picture, you can see that she does have a forward head and rounded shoulders. Basically, the shoulder blades are tipped forward and the neck appears very, very short because of the position of the levator scapula. The clavicles are affected in how they lie, and they should be horizontal, but in this rounded shoulder posture we won't see that. The AC joint may be lower than the SC joint. So the AC joint is actually the joint at the tip of the shoulder where you see the little knob of bone on the tip of her shoulder, and we'll actually find that that point is lower than where the clavicle meets the sternum, and that's the sternoclavicular joint. Technically, those should be level, and in this posture, we'll see a depressed clavicle where the SC joint will actually be higher than the AC joint. And there is a forward tip of the scapula, so if you look at the acromion, it's moved forward according to the humerus, so that acromion joint, a little bony landmark right above the glenohumeral joint, will be more than 2/3 forward in the glenohumeral to humeral head relationship. If you take a look at the scapula, they are tilted, and this is a winging. It's called a pectoralis winging, generally from a tightness of the pectoralis minor. So it's not the typical winging that we talk about from the serratus anterior. If you notice, it's actually the inferior angles or the points of her scapula that are sticking out on her back because of the anterior tilt of that scapula. In a serratus winging, we would see the medial border standing out rather than just the tip of the scapula. And we'll talk about this more when we go and visit the clinic. Just to talk a little more about what's happening in the shoulder blade when the forward head starts to take place, in our scapula we strive for an equal balance in our scapular force couple. When the arm is raised, we have scapulohumeral rhythm, and we'll see the scapula glide in upward rotation to allow the humeral head to move in the glenohumeral fossa. So as that scapula glides up, the humeral head can glide down and protect the precious tendons of the supraspinatus and infraspinatus that are passing underneath the acromion. If that scapula is not able to upward rotate at a speed and get out of the way, what we find is actually shoulder problems from that. So the force couple that's responsible for upward rotation of the scapula is very, very important, and it includes the upper trapezius, and you can see it here in the picture labeled U, the lower trapezius, and it's labeled L, it's the dark one there on the bottom, and the serratus anterior that's going off to the right side and labeled with an S. These three muscles are going to be the muscles that will actually rotate that scapula upward and keep a normal, healthy scapulohumeral rhythm to protect the rotator cuff muscles of the shoulder. Now, what happens in the forward head posture is that the levator scapula becomes very, very powerful and short. And that levator scapula attaches to the medial border of the superior angle of the scapula, and it is actually causing downward rotation of the scapula. So there are two opposing forces to this good couple, I call them the good guys, that are rotating the scapula upward. And these two opposing forces are the levator scapula and the rhomboids. So if we get a lot of power in that levator scapula because of a forward head posture, we start to see problems occurring in the shoulder because normal scapulohumeral rhythm cannot occur. So one of our goals in lengthening the levator scapula is not only to reduce the forward head posture, but to encourage normal healthy rhythm of the shoulder and the shoulder girdle. And the upper trapezius and levator scapula function in two different ways and also in two similar ways. They both will shrug the shoulder, and they do this in unison when the arms are down by your sides. But the upper trapezius is an upward rotator of the scapula, and the levator scapula is a downward rotator of the scapula. So we'll talk about this with the exercises, and you'll realize that you really need to do your shrugs with your arms overhead so that we lengthen the levator scapula and work the upper trapezius, or the good guy, in this relationship. And we'll talk about this more. We'll be having a shoulder lecture soon that you'll be able to take advantage of, and we'll go into greater detail on the muscles of the scapular area and how they relate to normal, healthy function of the shoulder. So now that we've talked about those muscles and how they relate to each other, let's talk a little bit about muscle imbalance. Muscle imbalance describes the situation where some muscles become weak and other muscles become short, losing their extensibility. In these situations, muscles can inhibit each other, and poor relationships can develop. And really, this is what's happening in a forward head posture. The deep neck flexors in the front are getting very, very powerful, and the extensors in the back cannot overpower them. So we have a poor relationship where some muscles are becoming too powerful and they're inhibiting the muscles on the other side. So what we see is a lack of balance. And these muscles need to gain length, they need to adjust their strength, but most importantly, they need to work together. And this is really how I think Pilates changes my practice. Because instead of saying, okay, stretch your levator scapula, and sending the client over to do a stretch for their levator scapula, I do a full functional movement using the Pilates equipment or a piece of equipment that's a prop in Pilates with a visual cue to encourage them to do normal healthy movement where that lengthening and strengthening are occurring at the same time, and there's a neurological education for a new movement pattern that this person will begin to use throughout their daily life so that they can maintain this healthy balance between the muscle groups. So I want to talk to you about upper cross syndrome. This is a syndrome that was initially defined by Yonda, and it's basically talking about this muscle imbalance that creates a forward head posture. Yonda would see a lot of this posture, and he wanted to identify why. Why do people have this posture? And he said basically it's just part of a general imbalance that involves the whole body. We have weakened deep neck flexors in the front. And across from that, lower in the back, we have weakened scapular stabilizers. The overactive muscles are directly in the opposite X. We have the upper trapezius and the levator scapula that are overactive. And we have an overactive pectoralis group. So what we're seeing is that rounded shoulder, forward head posture feeds itself with this poor relationship, which we can call the upper cross syndrome. Yonda created two different groups of muscles, and these were muscles which he anticipated and studied that would generally become weak and inhibited or generally become short. And he listed these muscles in the neck and shoulder area. And he said that, the lower stabilizers of the scapula, this would be the rhomboids, the serratus anterior, the middle and lower trapezius, tend to become inhibited. They're postural muscles that tend to get weak and be inhibited by tight or strong muscles. Also included in this group are the deep neck flexors, the suprahyoid, and the mylohyoid. Now he said the ones that tend to become short are the pectoralis major and minor, the levator scapula, the sternocleidomastoid, and the upper trapezius. And this is exactly what we're seeing in that forward head posture. So now let's look at where we should focus. Basically, when we look at a forward head posture, and we see this in our client, we need to be concerned with the coordination, timing, and sequence of activation of muscles, not with individual muscle strength. So if we go in and we manual muscle test a muscle, we're probably not going to find it weak. But according to its balance with another muscle, it might be weak. So what we need to look at are relationships. And I call it family counseling. And this is how I explain it to my clients. I say, if you were having trouble with your husband and you weren't getting along and you decided to go out for counseling, if you sent only your husband to counseling, you probably would not be successful. Because in one way or the other, you're both involved and you both need to learn to work together. It's the same with these groups of muscles. I often even break it down further by saying, you know what? The kids are involved too. So are the grandparents. So as we go down through these muscles, it might initially be a short levator scapula. But you know what? I think some of those other muscles, like the serratus anterior, the mid-traps, they're affected by that. And both muscles need counseling. And then we could even go deeper and down into the pecs and into the sternocleidomastoid and say, all of those are affected too. So we need to all learn to work together. So the best kinds of exercises and the best focus that we can give our clients is general exercises that incorporate good posture and good movement patterns that they can practice over and over. And they're not really working for strength, they're not really working for flexibility, they're working for balance. They're working to teach their body to work together. When I look at someone who comes into the clinic who has a slight forward head posture, I will generally look at 3 basic movement tests to make sure that this is truly what's going on. I'll have the person lie flat and have them do flexion of the head. So basically they're trying to pick their head up from the table as if they were going to do a curl up. And I really won't give them any instructions on how this happens, but I'm going to look at the relationship of the sternocleidomastoid to the deep neck flexors. How exactly does their head pick up from the table? Do they lead with their chin and actually extend their cervical spine as they come up? If they do that, we know that the sternocleidomastoid is dominant and the deep neck flexors are inhibited. What we would prefer to see is an actual flexion of the cervical spine where the chin comes down and the back of the neck lengthens as they come up. So that's one good way to look at their movement pattern, and even a way to set a goal for that client that you want to see that movement pattern change. I will also have them do a slow push-up from the prone position and take a look at what their blades do. What do their shoulder blades do? This is one position where we will often see that pec minor winging really happen. Right up from that bottom, we'll see the tip of the scapula point straight up to the ceiling as they bring those hands into place and begin to press into the table. So this is one good way to see what's going on as far as the pecs are concerned and their power in this relationship. I will also take a look at shoulder abduction in sitting with the elbow flexed. I will note the start of scapular elevation. Normally, scapular elevation or a rise in the scapula will begin at 60 degrees of shoulder abduction with the elbow flexed. Now, if I start to see it sooner, then I know there's shortness. There may be shortness in the upper trapezius, levator scapula. Things are elevating before they should. And it shows me that there's a powerful relationship there where there's shortness or dominance in the elevator muscles, and the serratus anterior may be inhibited by them. So these are 3 basic movement tests that you can look at to give you an idea that this is occurring, and then you can use them as goals or measurements to show progress with your patient or your client. This slide sums up something that you should never forget when working with your clients. No therapeutic approach is sufficient unless body posture is generally improved. Whatever the cause of the client's problem, special attention should be given to posture. This can be time-consuming and is often neglected. So you could work out with your client 3 times a week, an hour each time. You could have a great exercise program that's catered right to their needs. But if you don't change what they do all day, every day, you're not really going to make a change in their pain, complaints, or in their ability to prevent injury. So remember to always look at their posture, give them tips and ideas on how to keep themselves in good posture throughout the day, and to work on the muscles that you're targeting in your program in their daily life as well. Here are the references for this presentation.